All right, neurology, last slideshow for this course, so let's do it. Parkinson's disease. Notice I said Parkinson's, force of habit. The newer nomenclature suggests that we drop the S's on most of these diseases just because they don't belong to the person, they're just named after them. Parkinson's disease has been around for a long time, and it's related to a lack of dopamine that's produced by the substantia nigra in the brain. Balance and coordination require a balance of acetylcholine and dopamine. And the problem with that is that if you have too little dopamine, the acetylcholine overwhelms, you start having a lot of tremors, you start having a lot of symptoms. The symptoms you get are usually a resting tremor. So the tremor happens when they're resting, they go to reach for something. The tremor doesn't always completely go away, but it usually gets substantially better. Bradykinesia, which just means slow movement. Rigidity, they have to concentrate so that their limbs look rigid. We used to call that lead pipe rigidity. Nobody knows what a lead pipe feels like anymore. Posture and balance problems. They have a festinating, propulsive gait. Festinating is usually kind of small steps. And what will happen is those steps will usually get progressively longer, and they'll actually get to the point where they really can't even control their gait. They'll just, almost be running. Retropulsion, they're standing there and you bang them in their shoulders, they'll actually start moving backwards. Most of us take a step or two and right ourselves. People with Parkinson's disease can't do that. They just keep going. They'll have speech changes. Their speech will become lower volume. They'll become more garbled. They'll also, in very early stages, start to write differently just because they have to concentrate, so they'll often start writing smaller. So if you notice somebody has small writing, Parkinson's disease is something to keep in the back of your mind. So for treatment of Parkinson's disease, we can actually give an anticholinergic. We said it was a problem with the balance between acetylcholine and dopamine. Well, the problem is that we now have the ability to give dopamine and raise it. And also anticholinergics have lots of side effects, that old can't see, can't spit, can't pee, can't defecate thing, right? So we do avoid them if we can. So they're rarely used for Parkinson's disease anymore. Now, MAO-B inhibitors are interesting because MAO, monoamine oxidase, is an enzyme that breaks down all sorts of things. The problem is that when we give the non-selective inhibitors, it interferes with the digestion of certain foods, things that are, fermentation and certain types of foods. And therefore, people have a lot of dietary issues, a lot of dietary side effects. With the MAO-Bs, they're pretty selective for the types of medications that we're talking about. And so we do the MAO-Bs on a regular basis, and they almost seem to decrease the progression of the disease as well. So that's kind of interesting. Levodopa is a precursor to dopamine. We give it, it crosses into the brain and is converted into levodopa. And levodopa is converted into dopamine, I should say. We will often give it with a medicine called carbidopa. Carbidopa is misspelled on this side. It should be C-A-R-B. But carbidopa does not cross the blood-brain barrier, but it actually, it doesn't literally block the effect in the stomach and the other areas, but that's the effective upshot of what it does, is it decreases the side effects, because plain levodopa causes a lot of GI side effects, causes a lot of problems. But the carbidopa blocks all that. So if you increase the carbidopa, you will not increase the effect of the levodopa, but you will decrease side effects. That's a common mistake that people make. There's also some dopamine agonists, bromocriptine, Mirapex. We use those more commonly for things like restless leg syndrome, and they seem to work pretty well. We will use them in people with PD once they've sort of worn out on the levodopa, because they do seem to get less and less effect with it. There's another medication that interferes a different enzyme, the COMT enzyme, that will also improve the effect of the levodopa. It's a progressive condition. They'll get urinary retention. They often have an associated dementia, and it's hard to parse that dementia away from Alzheimer's disease or multi-infarct dementia, but they'll have the tremor. Very frequently, people with Lewy body dementia have very similar symptoms to PD, and that's a hard differential to make as well. They'll have falls, they'll aspirate. It can be a nasty disease to have. MS, switching gears here a little bit, multiple sclerosis. It's a very hard diagnosis to make. Oftentimes people have gone 7-8 years with symptoms without having a diagnosis. The most common thing that really tips you off is double vision. With double vision, we'll often do the appropriate testing quickly. But lots of times people won't have that. They'll have a little bit of vertigo. They might have some tingling. They might have some weakness. And the only real way to know is to do an MRI of the brain and the C-spine with and without contrast. So it's almost effectively 4 MRIs. And then you catch demyelination. Very frequently that demyelination comes and goes, and some people have residual of demyelination, but that also can be from Lyme disease, it can be from migraine, there's a bunch of things that it can be from. So how do we manage MS? Well, MS does seem to be an autoimmune process, so we have figured out that there's a number of different ways that we can manage it. We'll use the monoclonal antibodies such as Tysabri. We do need to make sure they don't have the John Cunningham virus, so we check for that antibody just because there's a incidence with these monoclonal antibodies of something called progressive multifocal encephalopathy, and those folks will have this very nasty encephalopathic process. With MS, we'll give high doses. We'll often give 1,000 milligrams of Solu-Cortef or Solu-Medrol. And they do seem to respond and don't have a lot of side effects, interestingly. Other medications we use for MS affect other immunomodulators. The NRF2 modulator is something that Tecfidera affects. These are very expensive medications. It works in relapsing remitting MS, but not primary progressive. As noted, it is expensive. The Gilenya is another one that's very expensive, and it does cut the relapses down. So TIAs. So TIAs are transient ischemic attacks. They're basically stroke symptoms that last 24 hours or less. There's also stroke symptoms that go completely away in a matter of a few days. Those are sometimes referred to as RINDs, or reversible ischemic neurologic deficits. Very frequently, now that we have MRI, we'll notice that those folks will usually have some kind of evidence of a little bit of infarct in their brain. Years ago, we didn't find that. But TIAs come and go. They're almost like the angina equivalent in regards to cardiovascular disease when we're talking about brain issues. So how do we prevent TIA and stroke? We keep their blood pressure under control. We manage their lipids. We encourage them to be active. We make sure they don't have AFib, or if they do, we put them on anticoagulation as suggested by the CHADS-VASc score. CHADS-2 is an older version of that. Very frequently, they suggest doing early referral. The challenge, of course, is that if you've got somebody that's getting better or their symptoms are already gone, there's nothing really that the ER is going to be able to do for those people other than some laboratory testing and EKG to make sure that they are not currently in AFib, and a CT. Now, a CT does not diagnose a blood clot in the brain. It only is effective, at least in the early stages, to rule out a bleed. And so we do that because we still sometimes give those people clot busters. So we said 3 hours. I think they've actually extended that. So just make sure you keep up with the latest literature for that. But in the office setting, if somebody has symptoms, I'm usually going to send them. There is some evidence that if you go to the hospital by ambulance, you're more likely to get a CT scan. Again, depending on the severity of your symptoms, you'll likely get a CT scan, and that's probably why those people get the CT is that they actually had worse symptoms, as opposed to encouraging people to call an ambulance for the world's mildest symptoms. Very frequently, they'll go, the ER will do labs, the labs all look fine, they're not an AFib, and they say, oh, you're getting better, follow up with your PCP. They'll often say follow up with neurology as well, but neurology will say, oh, you know what, you're not actively having anything, go see your PCP, I'll wait for a referral from your PCP, and I'll see you very frequently several weeks or a month later. And what does a PCP do? We manage blood pressure, we manage cholesterol, we manage all of those kinds of things. Aspirin is a good secondary prevention, usually the 325 milligram tablet. The risk of bleeding is not insubstantial, so if people haven't had stroke or heart symptoms, the evidence seems to be that you probably should not put them on an aspirin. But many times patients want this, and in general you're going to get in a lot more trouble for something that you didn't do than something that you did do. So if you're trying, at least, patients will cut you some slack on that. So a lot of people go on aspirin and tell you they're going to. But as I say, primary prevention, the evidence is very weak, if not non-existent. Anticoagulation, you do aspirin alone for a low-risk TIA. There's something called the ABCD2 score. For the high-risk TIA, sometimes they'll use aspirin plus Plavix. Again, to be honest with you, I usually just start them on aspirin and then let the neurologist add the second one if they want to. Sometimes people are even put on Coumadin or Eliquis, but not commonly. Agrinox is aspirin and dipyramidol. There seemed to be some evidence that that decreased the risk even more. We've reevaluated that, and we think probably the evidence is that aspirin is probably just as good. Plavix, now that it's generic, is actually very cheap. This is an old slide that says it was expensive. It did used to be expensive, but the ABCD2 score is age, blood pressure, clinical features, whether or not they've had any weakness or speech issues, whether they're diabetes, the duration of their symptoms, and then you figure out that score, and that's used to figure out the aggressiveness of your anticoagulation. It's a very interesting question when someone has a TIA, and this is one of those hard things as a PCP that you have to decide, and neuro is not often, at least around here, that much of a help, just because in Portland they're very short on neurologists, and in southern Maine we're even more short on neurologists. Very frequently we'll get an MRI. Many people get an MRI and an MRA, just because, you know, again, you can't get in trouble for the test you did, you get in trouble for the test you didn't do. It is often best just to get a neuro consult, but as I say, very frequently that's hard to do. The MRA is angiography, of course, and it's actually the equivalent of an MRI, but with time factored in there. So what do you do with an asymptomatic carotid bruit? We do know that it probably suggests that they do have vascular disease. So we do aggressively manage their blood pressure. We aggressively manage their cholesterol. Gorel said that you had to have at least 50% occlusion to have a bruit. That means that by the time you have a bruit, it's a pretty substantial occlusion. And once you have 100% occlusion, the bruit goes away, doesn't it? Can you have 100% occlusion in both carotid arteries? Sure you can, as long as your circle of Willis is intact, which in 85% of patients it is intact. Another reason to sometimes get an MRA. Those folks actually get adequate circulation just from those vertebral arteries in the back. So a carotid endarterectomy, sometimes abbreviated CEA, in asymptomatic patients, in general, the feeling is that the risk of surgery is probably greater than the benefit. We do think that once they've started having symptoms, that calculation changes. Once they've had, TIA type symptoms. We don't know really the appropriate role of surgery. Different centers will tell you different things. Some will say they have great outcomes. Some it's pretty questionable. It's an interesting question, I think, of when to check for a bruit. Some people check with every physical exam. I only check if I've got somebody that's had symptoms, because I'm not going to refer anybody with an asymptomatic bruit. And right now, to be honest with you, it's actually kind of hard to get a carotid ultrasound approved unless they've had symptoms. So we'll talk a lot about migraine. There's other headaches, cluster headache. They get a cluster of them. They get dripping of the nose and dripping of the eye. Triptans will work for that. We'll talk about muscle contraction headaches. And don't forget TMJ dysfunction on your differential. So migraines, lots and lots of migraines. I did borrow 6 or 8 slides from Karen Gilbert, who is a nurse practitioner from Dartmouth, who does a lot of migraine work. She said she wouldn't mind. So it again, 18% of women are affected, 6.5% of men. So don't assume because it's a man that he doesn't have migraines. They definitely still do have migraines, but a bit less affected. Lots and lots of migraineurs out there. And the peak incidence is 25 to 35. Women do get it more than men. Again, 18%, so 1 in 5 women have migraines. And about 80% of people will have a family history. So that is a good question when you have somebody that has onset. So a lot of people will have neck pain. So some people will come in with what they think is a neck strain sprain. But you do need to be very aware that sometimes this is actually a migraine-associated neck pain. So if you've got a headache as well and neck pain, you definitely want to think migraine. Most people will have some kind of a trigger for a migraine. Very frequently it's stress. Some people it's odors. Some people it's changes in sleep. Some people it's changes in their caffeine intake. I always tell people that migraines are a warning light on the dashboard of life. You've got too much stress, you're not sleeping enough, you're not eating well, you're not exercising enough. Keep an eye on all of those. The other thing that's a hard differential sometimes is trying to decide whether it's a sinus issue or whether it's a migraine. Many of the patients that have been diagnosed as sinusitis or sinus problems actually have migraine. And so it is something to keep in mind when you've got people and they've got those, runny eyes and runny nose and congestion. Migraine will do all of those things. So sometimes it is worth a trial of therapy for migraine. And again, the number of people that have been diagnosed with sinus headache that later receive a diagnosis of migraine, maybe as many as 40% or so. Predictors, again, most likely to be female, but again, 1 out of, well, if it's 20% for women, it's 1/3 of that, so it's about 6 or 8% for men. Usually they'll have the nausea, they'll usually have higher pain. Very frequently, patients will come in and say, I had a migraine. And you're like, well, what do you mean? I just had a really bad headache. Well, unless it has elements of photophobia, unilateral, the things that classify something as a migraine, it's not a migraine. It's just a really bad headache. There's lots of different types of headache. Cluster headaches are almost the same thing as migraines, but they usually do have the runny eye and the runny nose just on one side. If you're in a setting where you can give them oxygen, sometimes oxygen is very helpful for cluster headaches. Muscle contraction headaches usually are band-like headaches either in the frontal area, hat band headaches, or band-like back in the occipital area. They can be just as severe or more severe than migraines. Again, people with migraines often have substantial disability during their headaches. They'll be sensitive to light and sound, and a fair percentage of them have aura. That's particularly important to decide in women, because if women have a migraine with an aura, they really can't receive oral contraceptives. SNOOP is just a mnemonic to help you decide, is this a headache I need to worry about more? systemic process. So if they have systemic signs, especially if it's neurologic, thunderclap headache, that sudden onset headache is sometimes a subarachnoid hemorrhage. Older people rarely have new onset of migraines. It can happen, but it is not common. And again, if you've had somebody that's had a certain pattern but has a really different type of headache now, you'd want to be aware of that. So again, the primary headache types are migraine without aura, migraine with aura, and especially important to diagnose that in women. Chronic migraine, cluster headaches. There are also some unusual headaches called cough headaches, where they only get a headache when they cough. Exertional, sexual activity, and there's a rare but sometimes very problematic headache called hemicrania continua. And again, about 60% of migraine sufferers have that aura. It can be either a vague awareness, a change in mental status, neurologic changes. They become very sensitive to light. Sometimes they'll actually have decreased appetite, diarrhea, lots of different things that can happen. To have a migraine and for it to meet the diagnostic criteria of without aura, you have to have a headache that lasts 4 to 72 hours. You don't think it's due to anything else. You have 2 of the following: unilateral location, pulsating quality, moderate or severe intensity, and aggravated by physical activity, as well as either nausea or vomiting or photophobia and phonophobia. So without meeting that criteria, it does not meet the criteria of migraine. And again, with aura, you want all of the criteria for migraine without aura. It's not attributable to something else. And you have either a recurrent symptom that's neurologic, an aura symptom, and that the aura symptoms last greater than 5 minutes and less than 60, and that the headache begins within 60 minutes of onset. So some migraines last a long time. 4% of them last more than 2 days. Some people will call this an intractable migraine. The majority of them are a day or so. Some people it's only less than 4 hours. And these are untreated or unsuccessfully treated migraines. And again, you got to hit the migraine fairly early because we do feel that it sensitizes the nerves more as the time goes on. So we used to think that migraine was a purely vascular phenomenon. We do believe that there is a vascular component of either dilatation or constriction, and that's why a lot of these medicines will affect that. That's what caffeine predominantly affects. But we now know that it's multifactorial, that it is blood vessels, but it's also the nerves that the blood vessels are affecting and whether or not those nerves get sensitized. Migraine treatments, the triptans, basically are serotonin medicines, which affect both the vascular and the nervous components. They're short-acting rescue medicines. The ergots do something similar, but have a lot more side effects, so we rarely use the ergots anymore. The monoclonal antibodies will actually decrease any immune response. So if you have something that's a little bit of an autoimmune type process, it will interfere with that. Usually that's that calcitonin gene-related peptide. Does seem to work pretty well, although to be honest with you, I'm not sure that we understand the pathophysiology all that well yet, but we do know that they work. 3 medicines. Aimovig is a good medicine, but it causes a lot of constipation, so people don't like it. Emgality is a newer one that seems to work a bit better, came out second. And then the Ajovy is now being pushed by that drug company, and I think it might even be a little cheaper, and so some formularies prefer it. But seizure disorders. So you won't see a huge number of people with seizure disorders in primary care, but you'll definitely see some, and you'll see more in the hospital. When you have somebody that has a passing out episode, now passing out by definition is syncope. The problem is that if it's a seizure, it is not syncope, it's a seizure. But those two can present very similarly, that sudden loss of consciousness. Sometimes it's hard to diagnose. Vasovagal shaking will actually occur if you have a person that has a vasovagal episode, vasovagal sympathy. They will have a little bit of shaking of their arms and legs. Some people mistake that for the acute tonic-clonic reaction in a seizure. You need to be careful. Pseudoseizures are a seizure of psychological origin. They are not faking. They are not voluntary. They just occur when the brain decides they're going to occur. They don't occur at really inopportune times usually. They don't occur when people are driving. They don't occur when they're up at a height level. And they usually don't fall flat on their face and get a facial fracture or anything. They usually occur when the person's sitting on a couch. These can be very problematic and can be just as hard to treat as regular seizures, and can really interfere with people. I have a couple of patients that are on disability because of severe pseudo-seizures. The neurologists can be somewhat helpful with that, but they often need psychological intervention as well. EEG, I've been taught to do a sleep-deprived EEG if I'm looking for seizures, but some kind of an EEG, imaging of the head is very commonly done to make sure that there's not a tumor or something else that's causing the seizures. Laboratory testing, make sure they're not profoundly hypoglycemic or something like that that cause the seizure. And then further evaluation is usually done by neuro. If they are on seizure medicines, you check a level. If they're on Tegretol, you check a Tegretol level to make sure it's therapeutic. Those people don't necessarily even need to go to the hospital. You just get the appropriate workup. New onset seizures, because they can be associated with some more serious things, they usually do go to the hospital for a workup, but somebody with chronic stable seizures, you usually won't send them. And you definitely do want to co-manage. It is good when you have good communication with the neurologists. That's not always as possible as you'd like it to be. Bell's palsy is a issue of the 7th cranial nerve, the facial nerve. They'll get a dramatic droop. With stroke, they usually do not lose the effect of their eyebrow. They can usually move their eyebrow. In Bell's, they'll always lose that, or essentially always lose the ability to raise that eyebrow up. So that is a way to differentiate stroke and Bell's. Bell's is often associated with some kind of a bacterial or a viral illness. We used to say that herpes simplex was the most common one, but we now know that Lyme is probably just as common. So if somebody has Bell's palsy, you definitely do want to do testing for Lyme. Some people will even do empiric treatment for Lyme, although most of the people that get Bell's have had Lyme long enough for the blood test to come back positive. Some people still do antivirals. It's not done as commonly as it used to be, and some people will actually do prednisone for treatment for the Bell's. Tic de la Rue is another condition. That's the trigeminal nerve. That's the 5th cranial nerve. These people, and I've only seen a couple in my life, will have this horrible pain. I mean, it's a extremely severe pain, but it only lasts a minute or so. And so it's unilateral, it's lancinating. It's as if somebody took an ice pick and actually just stuck it in their face. It can actually go as far back as sort of halfway back on the skull. So just because it's up in the hair, don't cross tic de la Rue or trigeminal neuralgia off. Most of these people will respond to Tegretol. Some get baclofen. Some actually need a rhizotomy. The percentage of patients that commit suicide with this is much higher than in most other chronic conditions because it's a horrible disease to have. There's lots of neuropathies. Carpal tunnel is a very common one, where you'll have compression on that median nerve, where you'll get tingling in the hand. I think in your physical exam, physical assessment courses, you've learned how to do the Phelan and Tinel signs. Treatment often involves splints, sometimes surgery. I usually just start with night splints. Most people won't wear them during the day, and a fair percentage of people will get better just wearing splints at night. Thoracic outlet syndrome is pain down the arm. There is a test called the Adson's test that you can actually see that there's decreased circulation with a certain movement of the head. These people can be hard to get better. They sometimes will have a cervical rib. So normally the ribs are only on the thoracic vertebrae, right? 1 through 12 ribs, 1 through 12 thoracic vertebrae. The lumbar don't have any, the cervical don't have any. Some of these people will actually have a rib sticking out of C7. Sometimes removing that can help, but it can get pretty complicated. Cervical radiculopathy can cause numbness and tingling down into the arms. If you take your thumb and index finger and make a circle and then lift up your other fingers, you can actually make a 6. That's actually the dermatome for C6. This is something that you just have to have a dermatome chart, and you have to look stuff up, and you have to know whether or not it's the distribution of a spinal nerve. The peripheral nerves sometimes have multiple spinal nerves coming into them, so that an ulnar radiculopathy, an ulnar neuropathy will often present very differently from a radiculopathy. A radiculopathy, by definition, is a spinal nerve. Meralgia paresthetica is entrapment of the lateral femoral cutaneous nerve. It's basically the outer part of the upper thigh. It'll go numb. Patients won't know why. Sometimes it's because they've had too tight of a belt, they've got a new car, and the angle's different. Alcoholic and diabetic neuropathies are often stocking distribution, but they can be extremely painful as well, and many times you'll need to use a gabapentin or some type of similar medicine to treat those. This is a dermatome chart. It's not the best I've ever seen, but the point is just that if you have something that has pain in this area, you're going to follow that dermatome down. Remember that there's only 7 cervical vertebrae, but there's 8 cervical nerves. So the little finger is actually the C8 dermatome.